Good afternoon. I'm Dr. MRUDULA. I'm here to talk about locally advanced carcinoma breast. So, locally advanced carcinoma breast, it is divided. It includes the TNM staging 3A, 3B, 3C, and inflammatory carcinoma breast, which is T4D primary tumor. That is stage 3B. So, stage 3A includes T0N2, T1N2, T2N2. T3N1, T3N2. 3B includes T4N0, T4N1, T4N2. 3C includes any T and N3 with no metastasis among all this. So if there is presence of metastasis, it becomes an advanced carcinoma. So the stage just before the advanced carcinoma is a locally advanced carcinoma breast, for which management we are going to discuss today. So the presenting features will generally be a lump in the breast with skin involvement, that is ulceration, dermal infiltration, erythema over the tumors, and may be involved with involvement of the serratus and intercostal muscles, and axillary nodes may be involved, which may be fixed to one another or to other structures. So this is a CA breast where you can see the nipple involved, and there are multiple nodules. There is a big ulceration with the skin involvement, the presence of lymph nodes. The same thing here. So there are involvement of some lymph nodes and axillary tail of pens. It is in the upper outer quadrant of the breast. Workup includes a medical history, clinical examination, CPP monitoring to rule out anemia, neutropenia, chest X-rays for lung metastasis, rib and spine metastasis, osteolytic lesions, and bilateral mammography and ultrasound abdomen to know the size and location of the tumor, and also the exact size, and in order to assess the size of the tumor post chemotherapy, and fine needle aspiration and core needle biopsy or incisional biopsy to determine the type of carcinoma and to know the hormone receptor status, ERPR status, HER2 status. And auxiliary staging is important for nodal staging, for staging of the tumor, and sentinel lymph node mapping. And other adjuvant therapies like bone scan, MRI, CT abdomen, PET CT can be done. So the management generally includes a neoadjuvant chemotherapy, the therapy which is given before surgery, and followed by surgery, which is a modified radical mastectomy or a breast conservative therapy, or which may include axillary dissection based on need, and adjuvant chemotherapy and radiotherapy. So candidates who are in whom the neoadjuvant chemotherapy can be given are those with large size tumors more than 5 centimeters, with those with an extensive lymph node enlargement and with direct chest wall or skin involvement, and those who are considered inoperable without distance, but without distant metastasis. Like suppose a tumor is very big and it is involving the chest wall and it cannot be operated, but there are no metastases in the liver or in the brain or in the bone, then such patients can be considered as a local advanced carcinoma, and you can go for a neoadjuvant chemotherapy. And can also be given in inflammatory carcinoma breast, and those with the ER negative and HER2 positive disease, and those tumors which require downsizing of the of tumor before surgery. Suppose the tumor is very big and you think that cosmetic outcome is not possible with some tumors. So in those cases, you can downsize with neoadjuvant chemotherapy. So the common advantages of chemotherapy are neoadjuvant chemotherapy, that is reduction in the tumor volume, tumor downstaging, in vivo assessment of tumor response. Suppose if whether we can know whether the tumor is responding to the chemotherapy which is being given or not with regular assessment, and the less extensive surgical resection. You can go in some cases for patients who are willing and feasible patients, we can go for a breast conservative surgery after chemotherapy, neoadjuvant chemotherapy, and post-surgical growth spurt are abrogated, and early introduction of systemic therapy is possible, and response to chemotherapy serves as a marker for long-term better prognosis. So if they're responding to neoadjuvant chemotherapy, the same drugs can be used as a adjuvant chemotherapy later on, since the tumor is responding to the drugs. And since neoadjuvant chemotherapy is very useful, as we can do a multiple sequential sampling of the primary tumor, and for evaluation of biological changes during chemotherapy. There may be some changes in the cellular ATPs and all. So they can be monitored regularly, and the response can be monitored with neoadjuvant chemotherapy. So the basic disadvantages are it is started based on clinical or radiological staging. We do not know the metastatic staging of the patient. And overall treatment of over-treatment of small favorable tumors. Suppose the patient can be done a smaller surgery, but it is like some patients may be subjected to over amounts of chemotherapy, which is very much problematic for the patient. So extent of surgery is not confirmed. Loss of prognostic significance of axillary lymph nodes, and unknown relevance of surgical margin. Large number of drug-resistant cells may be present because before first chemotherapy, some tumor cells may become resistant. So there may be chances of chemotherapy drug resistance and delays in the effective local therapy. Suppose you're supposed to do a surgery as a primary treatment. Sometimes using a chemotherapy, the patient may not respond to the chemotherapy. So there is a delay, and you are increasing the duration of removal of the tumor. So the tumor exists in the body for a longer duration, and delay, which is causing which may cause a metastasis. So there is a delay in effective local treatment, and response of primary tumor may not correlate to the response of micrometastasis. So if the primary tumor is 5 centimeters, after neoadjuvant chemotherapy, test become 2 centimeters. So the tumor size alone has decreased, but you cannot say whether the micrometastases have decreased or not. So that cannot be assessed with a neoadjuvant chemotherapy monitoring. So that is a disadvantage. So best regimens for neoadjuvant chemotherapy are 5-FU, adriamycin, and cyclophosphamide, FAT regime, AC regime, CMF regime. So which are generally given in 6 cycles. And efficacy of anthracycline containing regimens is highest in terms of response rate. So anthracyclines have got a better response rate and a disease-free survival and overall survival. What are these? We'll discuss. So what are the basic regimens for neoadjuvant therapy? It is 5-FU, doxorubicin, and cyclophosphamide. 5-FU is given as by 100 milligram per square meter IV on day 1 and day 8. Doxorubicin is given as 50 milligram per square meter IV on day 1, and cyclophosphamide is given as 500 milligram per square meter IV on day 1. And the cycle is repeated every 21 days for 6 cycles. So every 3 weeks for 6 cycles. So there is another regimen which can be given as neoadjuvant therapy, that is doxorubicin and cyclophosphamide. Doxorubicin as 60 milligram per square meter IV on day 1. Cyclophosphamide 600 milligram per square meter IV on day 1. This AC regimen is repeated every 21 days for 4 cycles. So CMF regimen, it is cyclophosphamide, methotrexate, and 5-FU. Cyclophosphamide is given at 600 milligram per square meter on day 1. Methotrexate 40 milligram per square meter on day 1, and 5-FU 600 milligram per square meter on day 1. So again, every 3 weeks the cycles are repeated. Around 4 cycles are given as a neoadjuvant therapy. Adriamycin and cyclophosphamide. Docetaxel is given as 75 milligram per square meter on first day. Adriamycin 50 milligram per square meter on day 1. Cyclophosphamide 500 milligram per square meter on day 1. So the cycles are again given every 21 days for 6 cycles. So this is another regimen, that is docetaxel and cyclophosphamide. Docetaxel is given as 75 milligram per square meter IV on day 1. Cyclophosphamide 600 milligram per square meter on day 1, and it is cycled every 21 days for 4 cycles. So AC followed by paclitaxel. This is one more regimen where doxorubicin cyclophosphamide is followed by paclitaxel infusions, and these cycles are repeated every 21 days for 4 cycles. So the adverse effects of neoadjuvant therapy or any chemotherapy is nausea, vomiting, thrombophlebitis, gastritis. Thrombophlebitis is because of inflammation of the of the vein, which is in which the chemotherapy drug is being introduced and infused. And gastritis and diarrhea are because chemotherapy affects the fast or highly dividing cells. So gastric mucosa, hair follicles are rapidly dividing cells, so they are generally affected. So which causes gastritis, diarrhea, hair loss, constipation, and all. And bone marrow cells are also affected because of their high mitotic activity, which causes a pancytopenia, neutropenia, that is decrease in neutrophil count, decrease in all the blood cell count. And since there is decrease in neutrophils, there may be chances of infection. Patient may develop immunosuppression and myelosuppression and neurocognitive dysfunctions. So specific side effects include cardiac side effects like LV dysfunction, anthracyclines, trastuzumab, cyclophosphamide, taxanes. All these cause left ventricular dysfunction. Anthracyclines, they cause a late onset permanent cardiomyocyte damage, that is apoptosis and necrosis. So best treatment is to stoppage of the drug and diuretics, limit the total dose to less than 450 milligram per meter square. So cyclophosphamide, it is one important drug which causes hemorrhagic cystitis. This hemorrhagic cystitis is because of byproduct of cyclophosphamide. It is known as acrolein. So the best treatment is Mesna, which combines with acrolein and decreases hemorrhagic cystitis, and hydration and dose modification. Leukopenia, SIADH, and secondary cancers are also possible with cyclophosphamide. And 5-FU causes oral ulcers and hand-foot syndrome. Taxanes are known for peripheral neuropathy and motor neuropathy, and febrile neutropenia, decrease in neutrophil count and fluid retention. It's mostly dose dependent. Treatment includes dose modification, gabapentin, and venlafaxine. So neurocognitive dysfunction is more than 2 years after treatment may occur. So prophylactic modafinil or fluoxetine can be given, but there are less studies supporting that. And secondary malignancies, which are common, rare, but which can occur as AML and MDS. So neutropenia, neutropenia is decrease in the neutrophil count. It may be mild, that is less than 15,000 cells per cubic mm. Moderate, it is less than 10,000 cells per cubic mm. Severe, less than 500 cells per cubic mm. So chemotherapy-induced neutropenia typically occurs 3 to 7 days after administration of chemotherapy and continues for several days. So the poor predictors of so when you have to find, so neutropenia, what you have to see in neutropenia, and patients, which patients are poor predictors for prognosis is age more than 60 years with moderate neutropenia with febrile illness and hypotension, dehydration, inpatient status, and prior fungal infections. So what is the appropriate management for patients having fever and neutrophil count less than 5,000? You can start a broad spectrum antibiotic and granulocyte colony stimulating factor, which is known as filgrastim, which is given 5 microgram per kg per day IV or subcutaneous infusion for 2 weeks. The dose may be elevated or increased for each chemotherapy cycle. So first dose is given at least 24 hours after chemotherapy. And before admission of any chemotherapy, patients' blood counts and platelet count should be done, and it should be repeated every twice weekly. So when the absolute neutrophil count is more than 1,000 for 3 consecutive days, you can reduce the filgrastim dose to 5 microgram per kg per day. When it is more than 1,000 for more than 3 consecutive days, you can discontinue the drug dosage. If the ANC is less than 1,000 cells per cubic mm, you can start other granulocyte colony stimulating factors are PEG-filgrastim and TBO-filgrastim. You can also go for a stem cell transplantation in the presence of severe neutropenia. And corticosteroids, IV, and immunoglobulins may not be of big use in neutropenia. So preventive measures for neutropenia is good hand hygiene, dose modification, and minimizing the exposure to allergens, pets, and live plants. So taxanes. So what is the use of taxanes in neoadjuvant chemotherapy? Taxanes increase the rate of breast conservative surgery, and they are best when given with changeover non-cross-resistant therapy can be given when anthracyclines are not responding. Taxanes are the next level of drugs where the changeover can be done. And pathological clearance rate is very high is higher with taxanes when compared to other drugs. So assessment of response of the patient. Response of the patient is usually done after 4 weeks of chemotherapy, and pathological evaluation is best. Other examinations include physical examination, ultrasound breast, mammography, MRI, PET-CT, nuclear scan, nuclear medicine systemically uptake scans. So residual cancer burden is the size of the primary tumor, cellularity, number and size of nodal metastasis. It provides a quantitative value of residual disease and also is of prognostic significance. So measuring the residual tumor following neoadjuvant chemotherapy, we should see whether we should look for a dominant mass, presence of scattered nodules among altered stroma, presence of you should look for occult microscopic foci amongst the altered stroma and single cells also. So what are the changes which we expect after neoadjuvant chemotherapy? We can expect a reduction in the tumor size and number of tumor cells, reduction in the cytological atypia in the tumor histopathology, and acquisition of foam or apocrine cytoplasm, that is the tumor cells mimic the histocytes, and acquisition of lobar morphology in ductal carcinoma. So whether to know the response, we should know what is a response for chemotherapy. So response in a chemotherapy may be a complete clinical complete response or a pathological complete response. Clinical complete response is complete disappearance of a clinically detectable disease in the breast or regional lymph nodes. Suppose a patient has got a 5 centimeter lump before neoadjuvant chemotherapy. After neoadjuvant chemotherapy, there is a total disappearance of the tumor, primary tumor. It is called complete clinical response. Clinically, there is no tumor palpable after neoadjuvant chemotherapy. Pathological complete response is no residual invasive tumor or pathological assessment of radiotherapy. Suppose we are giving on a 5 centimeter tumor. Clinically, after neoadjuvant therapy, there is no tumor cells palpable. Even on pathological examination, if there is no tumor cell palpable, it is called a pathological complete response. Then partial response. If suppose a tumor size is 5 into 5 centimeters, and there is more than 50% reduction in the size of the tumor, it is called a partial response. So after chemotherapy, the neoadjuvant therapy, the tumor size reduces to 2 into 2 centimeters. There is more than 50% reduction, so it is called as a partial response. And progressive disease, when there is a more than 25% decrease in the size of the tumor. If the tumor is 5 into 5 centimeters, after chemotherapy, it has become 7.5 or 8 into 8 centimeters. So there's an increase in the size. So progressive, it is called as a progressive disease. And stable disease, there is no increase in the tumor size more than 25%. So when the tumor is not increasing in size for more than 25%, then it is called, suppose if the tumor is 5 into 5 centimeters, there is no actual increase in the size of the tumor. After neoadjuvant chemotherapy, the size of the tumor has increased to only 6 into 6 centimeters. There is no actual gross increase in the size of the tumor. It is called a stable disease. And when there is no response, that is even after chemotherapy, the same tumor size remains the same. It is called non-responsive tumor. So why do you need to know whether the tumor is responding or not? It is because you need to know about the disease-free survival and overall survival. What is disease-free survival? Disease-free survival is the length of the time after treatment ends during which the patient survives without any signs or symptoms of disease. And overall survival as the length of the time from either the date of the diagnosis or start of the treatment of disease that patients diagnosed with the disease are still alive. So disease-free survival is something, if suppose a patient is diagnosed to have a breast cancer or a breast lump, patient has come with a breast lump in January and diagnosed to have a breast cancer by February, and the treatment like neoadjuvant chemotherapy, surgery, adjuvant chemotherapy, radiotherapy, all this has taken up to 1 year. So in such, and after 1 year, the patient has survived up to 5 years after treatment. So in these patients, the disease-free survival is from the disease-free survival, the disease period is January to December. Disease-free survival is from December to the next 5 years. And overall survival is from January to December plus the next 5 years. So overall survival is lengthier when compared to disease-free survival. But both these are useful to assess the survival rate of a patient. So what is the impact of neoadjuvant chemotherapy and adjuvant chemotherapy on the patient? So neoadjuvant chemotherapy increases the overall survival of the patient, decreases the local regional recurrence. Like suppose after surgery, after treatment, the rate of recurrence after neoadjuvant therapy is less. And breast conservative therapy is possible in neoadjuvant therapy. And this is downstaging. If suppose the tumor size is 5 centimeters, later on tumor has come down to 2 centimeters after neoadjuvant therapy, that time the surgery is easy and breast conservation is possible, and disease downstaging is also possible with neoadjuvant therapy. However, the disease-free survival rate which we have talked, it doesn't vary in both. So for a chemotherapy to say whether it is responding or not, whether the patient is responding for chemotherapy, we have to give at least 4 cycles of chemotherapy and assess for the response. If for non-responders, even after 4 cycles, there is no change in the size or no change in the clinical condition of the patient. But in some cases, there will be a partial response. That is particularly about 25% decrease in the size of the tumor, or more than 50% decrease in the size of the tumor, but not complete decrease in the size of the tumor and clinical. So in partial response, we have to change the drugs. In complete non-responding patients, we have to choose for a different regimen. So non-responders, we have to go for a second line chemotherapy. We can add a hormonal therapy, and we can also add radiotherapy, or we can directly take the patient for surgery whenever feasible. So this is an algorithm of workup of a patient with stage 3A, 3B. So we have to do a metastatic workup. We have to go for after metastatic workup, we have to go for a neoadjuvant systemic therapy and assess clinical response. So complete or if there is a complete or partial response, we can go for a surgical therapy and followed by an adjuvant therapy. So if there is no response, that is even after chemotherapy, there is no decrease in the size of the tumor, we have to consider an alternative chemotherapy. And individualized local regional therapy can also be used. So after neoadjuvant therapy, what happens to the tumor? The tumor may shrink totally or to a certain extent. If the tumor shrinks, if possible, we can go for a breast conservative surgery or a mastectomy. And if the lymph nodes are the lymph nodes are present, post chemotherapy, if the lymph nodes are negative and sentinel lymph node biopsy is negative, we can decide about lymph node dissection and to do or not to do lymph node dissection. And after the surgery, we have to go for a chemotherapy, endocrine therapy, and hormone therapy with trastuzumab and radiotherapy, followed by following the chemotherapy. If the tumor does not decrease in size, then what to do? We have to go for a change the regimen of neoadjuvant therapy. If patient is responding, then go for surgery. If patient is not responding, you have to decide whether to go for a surgery or to do anything else. So this is a concise of a patient with neoadjuvant therapy or a large tumor or inflammatory carcinoma, we have to refer the patient to surgery if biopsy is not done. If it is already done, we can take the patient to a medical oncologist. There they'll work up completely about the receptor status on core needle biopsy, imaging of the breast, imaging of axilla, and biopsy of suspicious nodules are to be done. Imaging of the chest, abdomen, bones, brain are to done to rule out metastasis. Then baseline blood workup and cardiac scan if you are planning for a pre-chemotherapy or neoadjuvant therapy, and perform clinical examination, measure the size of the tumor with a tape or a vernier calipers. Then we'll start a neoadjuvant therapy, and after each cycle, the size of the tumor is assessed. And for responders, we can go for surgery followed by an endocrine therapy and radiotherapy. For those who are not responding, we can change the neoadjuvant chemotherapy regimen, or you can go for a surgery or radiotherapy. So after neoadjuvant therapy, we have to go for an MRM, which is a modified radical mastectomy. So and after NAT, we can go for MRM. After MRM, we have to go for an adjuvant therapy because it increases the distant disease-free survival. It increases the chances of disease-free survival. And radiotherapy decreases local regional recurrence. So which is better after neoadjuvant chemotherapy, what to decide? So either patient can go for a total modified radical mastectomy or a breast conservative surgery. So modified radical mastectomy is the best standard of treatment, but breast conservative therapy can be given for some patients who have very small tumors and with a total nodal response, and large tumors with a good response. And it is not indicated for inflammatory breast carcinoma because the extent of tumor involvement cannot be certain. Because breast conservation, we are only removing the tumor and we are conserving the breast. For inflammatory carcinoma, the spread is too much, but we cannot decide about the margins and we cannot say how much breast has to be removed. So criteria for breast conservative surgery after neoadjuvant therapy. So which patients can undergo BCS after NAC is those who have complete resolution of the skin edema, those tumor size is very small, and there is no evidence of multi-spendric lesion. If supposedly there are multiple tumors within the same breast, so it is very difficult to remove the entire tumor tissue. So there will be some residual tumor left. Don't go for BCS in a multicentric lesion, and absence of extensive intramammary lymphatic invasion. If there is a large amount of intramammary lymphatic invasion, again large amount of spread. So even after breast conservative surgery, patient has a chance of recurrence. So to reduce that, you don't do a surgery in such cases. And absence of extensive microcalcification, the same thing. So microcalcification is a sign of malignancy. So when there is extensive microcalcification, the tumor is distributed in all the quadrants of the breast, then doing a breast conservative surgery does not yield any results, good results. So advantages is best cosmetic outcome, and there is no need for additional reconstructive surgery, and operation may be easy, lesser complex. But disadvantages is you don't know about the positive margins. There may be positive margins even after conservative surgery. So it requires re-excision or total mastectomy again, and there may be chances of recurrence. So axillary lymph node changes following NAT. So sentinel lymph node biopsy, whether it is done before and after neoadjuvant chemotherapy. So there is higher chances of sentinel lymph node identification rates, and lower false negative rates when done before neoadjuvant chemotherapy. Sentinel lymph node biopsy is generally contraindicated after neoadjuvant chemotherapy because in the absence of suspected or documented axillary metastasis at initial presentation. So if there is a axillary lymph node presentation, it is better to do a lymph node biopsy prior to giving the neoadjuvant therapy. So this is something which we'll discuss now. So a clinically node negative disease. we have to go for a sentinel lymph node biopsy. If it is pathologically negative, you can go for directly NAT and there is no need of axillary dissection. If it is pathologically positive, you have to go for NAT. And after NAT, again, you have to go for an adjuvant axillary lymph node dissection. If the node is clinically positive and the node is palpable, you can directly go for a neoadjuvant therapy. And if the node becomes negative after neoadjuvant therapy, you can go for an axillary lymph node dissection. If the node remains positive also, you have to finally go for an axillary lymph node dissection. So adjuvant regimens of chemotherapy, like the neoadjuvant regimen, there are adjuvant regimens, there are non-trastuzumab based regimens, endogenous chemotherapies. You can see AC, TC, TAC, AC followed by paclitaxel, docetaxel, FAC, that is 5-FU, doxorubicin, cyclophosphamide, FEC, cyclophosphamide, epidicsin. All these regimens we can be given following for adjuvant chemotherapy. So hormone receptor status, ER, PR, and HER2/neu, you have to go for a surgical biopsy prior to neoadjuvant therapy. So the normal dose of trastuzumab is 4 milligram per kg, which is the loading dose, 2 milligram per kg weekly for HER2/neu positive disease. Tamoxifen 20 to 40 milligram per kg per day, aromatase inhibitors for ERPR for 5 years. Platinum agents for BRCA mutations can be given. So after locally advanced carcinoma, after mastectomy, every patient should be given a radiotherapy after surgery and chemotherapy. This radiotherapy decreases the localization regional recurrence. So radiation after NAC follow the pre-NAC staging for radiotherapy. So pre-NAC, if the staging after NAC, there is a chance of downstaging of the disease. So what is before NAC, whatever was the initial staging, based on that, we have to give a radiotherapy. And radiotherapy is a must after breast conservative surgery because it decreases local regional recurrence and increases the survival rate. So this is radiotherapy is given as 40 gyri per 16 fractions over 5 weeks. Post mastectomy, it can be given as 35 gyri for 15 fractions for 5 weeks to the chest wall and 40 gyri for 15 fractions for 6 weeks to the supraclavicular region. So this is a radiotherapy machine. So disadvantages of radiotherapy is lymphedema, decreased shoulder mobility, paresthesias, hypothesias of the upper limb, and acute skin reactions, radiation, pneumonitis, non-cancer mortality, primarily from the heart disease and lung cancer. So one more interesting topic is an inflammatory carcinoma breast, which is also a type of locally advanced carcinoma, which is an aggressive type. There is no tumor mass underlying. This is a specific feature about LABC. And there's involvement of dermal lymphatics within the breast and overlying skin. And overall survival rate is very poor, that is up to 30% only, 5 years. So it is rapid onset, it progresses within 3 months. And neglected breast cancer that causes a secondary inflammatory changes is not an inflammatory carcinoma breast. So the patient will have erythema, edema, warmth of the breast, pudgy orange appearance. Palpable mass may or may not be present, and axillary metastasis is common. So such patients in mammography, there is actually no abnormality, and there is presence of tumor cells within the dermal lymphatics. So these are the differences between inflammatory and non-inflammatory. So dermal invasion will be present here. Here the inflammatory changes are present. The dermal invasion will not be present. Here the carcinoma, the mass is not clearly delineated. Here it is clearly delineated. And erythema, edema involve more than 30% of the skin. Here they are usually less. Lymph node involvement are most common in more than 75%. Here it is approximately 50%. Distal metastases are very common with inflammatory carcinoma. They are less common at presentation for a non-inflammatory carcinoma. Yeah, positive tumors and trastuzumab and HER2 positive tumors. That's all for today's class. Let's meet in another class.